health monthly teaching program. We thought that as everyone else is thinking that some benefit must be coming out from the corona epidemic, and if we can connect online, which may be easier in fact than bringing you all over and spending all those carbon footprints. So today we will be focusing on extracorporeal blood purification, something which is very close to heart to not only pediatric nephrologists but also pediatric intensive care worker, and that's why we are expecting as an audience a mixture of pediatric intensivist as well as a pediatric nephrologist. And the this 1 hour program will be like Dr. Bottari, who is from Italy. She will be first giving a small a talk on an overview of the extracorporeal therapy in PIC, which is available, and then Dr. Humbert from Biocon Biologics will be talking a bit about what is the in Cytosorb, so a bit of hardcore knowledge of Cytosorb, and then we will be having Dr. Satya Prasad, who is from Hyderabad, the Rainbow Hospital, talking about the Indian experience, which like all of us will be eager to hear. So, without wasting much time, can I ask Dr. Botari to start sharing her slides?
Yes. Good evening, everyone. Thank you for this kind invitation. Okay, I will.
So, Dr. Botari is a consultant pediatric intensivist at Bambino Gesù, which I understand is means Little Jesus, right?
Okay, it's okay.
Does it mean Bambino Gesù? Does it mean Little Jesus?
Yes, it means little child Jesus. Yes, yes.
Little Jesus, and it is one of the premier children's hospital in Italy, because I know a number of their pediatric nephrologists working there. So
okay.
we do interact quite a bit. So I think without wasting much more time, Dr. Botari, it is all yours. If you can start your session.
Okay. Thank you. I hope to provide you an overview as complete as possible about the topic of extracorporeal blood purification therapy in pediatric intensive care unit. Starting from the origin, during the time of the Hippocrates and Galen, ancient physicians embraced the concept that human illness and disease emerged from an imbalance of 4 bodily components or humor: blood, phlegm, black bile, and yellow bile. Interventions such as phlebotomy or leech therapy were frequently performed in an effort to remove evil tumor and restore the human balance. Extracorporeal blood purification in pediatric and neonatal intensive care are historically represented by hemofiltration and plasmapheresis. But in the last years, new techniques of extracorporeal blood purification are emerging, and indications to this type of treatment are increasing in critical ill children in a wide spectrum of disease. In fact, as consequence of the morbidity deriving from new complex treatment, children develop very early multiple organ disease syndrome in pico course. Thus, the clinical scenario shifts from a single organ failure to multiple organ failure, and the primary renal disease is most often substituted by an acute kidney injury as complication of a systemic disease. The rationale of the blood purification is to remove a pathogenic agents of endogenous or exogenous origin from the blood. At the same time, the extracorporeal blood purification technique can directly or indirectly support one or more organs in state of dysfunction. Blood purification could be considered a sort of umbrella, embracing not only sepsis and hyperinflammatory syndrome, but also a spectrum of disease where the toxin should be removed actively and efficiently before to induce an organ damage. In this scenario, it is very important to deeply know the target molecules and their molecular weight in order to choose the best blood purification technique for the underlying disease. Sepsis is the archetypal of the hyperinflammatory syndrome, but in pediatric setting, a group of inflammatory disease can mimic sepsis. Hyperinflammatory syndrome have different etiologies and pathogenesis, immunological dysregulation, autoimmunity, infection, and from an initial involving of a specific partner of the inflammatory process can evolve to a systemic inflammatory response syndrome, to organ disease multiple organ disease syndrome by an involvement of multiple patterns of the inflammatory cascade. The syndrome include not only the sepsis, as I said, but the spectrum of the HLH, the hemophagocytis lymphohistiocytosis, and the thrombotic microangiopathies, such a new entity of the thrombocytopenia associated to multiple organ failure. Given the complexity of the inflammatory process and its impact in the immune system during the hyperinflammatory states, it's clear that an ideal therapy should mitigate the cytokine syndrome, not being able to act selectively against a single mediator of the process. Additionally, the therapeutic target should be not only the pro-inflammatory state, but also the anti-inflammatory mediators. Different theories were proposed to explain the mechanism of blood purification in this setting. First, Ronco suggested the process of cytokine removal could reduce the peak blood level of cytokine during sepsis, limiting organ damage and the multiple organ failure occurrence. Subsequently, Honoré and Matson proposed the threshold immunomodulation hypothesis, according to which removal of blood cytokine would ultimately lead to a removal of tissue cytokine and as consequent balance between the two compartments. The third theory by Di Carlo and Alexander is based on the concept that hemodialysis with an adequate effluent could favor an increase in lymph drainage and thus increase clearance of inflammatory mediator. More recently, Peng suggested that extracorporeal blood clearance could act as an immunomodulation, favoring immune reprogramming of monocyte neutrophil and deactivated lymphocytes. The objective of the extracorporeal blood purification therapy are multiple. The management of fluid overload, the immunohomeostasis of pro- and anti-inflammatory cytokine and other mediators such as endotoxin, the treatment of the impaired coagulation response and the related organ microthrombosis, and the mechanical support of organ perfusion during acute episode to allow time for response to traditional antisepsis therapy such as antimicrobials. Approach that could hold promise for improving outcome in pediatric sepsis include the continuous renal replacement therapy, the plasma exchange, and the hemoperfusion. The high volume hemofiltration is defined as a continuous high flow rate ultrafiltration with 50 to 70 milliliter kilogram per hour ultrafiltration or intermittent hemodialysis with 100-120 milliliter kilogram per hour ultrafiltration for 5 to 8 hours a day. The three main randomized control trial carried out in adults did not show any advantage of high volume hemofiltration over standard hemofiltration in terms of morbidity and mortality, and in particular of vasopressor requirement. And the most recent publication by Miao and other co-authors in pediatric population analyzed 155 septic children and compared high volume hemofiltration with the standard hemofiltration. The authors did not found any difference in terms of mortality, neither in plasma level of inflammatory mediators or hemodynamic variable. The same results were reported by Cui and other co-authors in a single center randomized trial in children with secondary hemophagocytic lymphohistiocytosis. Thus, following these results and this evidence, today the minimum effective dose for venous hemofiltration recommended remain 35 to 40 milliliters per kilogram per hour. Therapeutic plasma exchange is a procedure in which blood is passed through a device that separates and removes the plasma for the cellular components. The removed plasma is discarded to be replaced, and the plasma that is removed can be replaced by fresh frozen plasma, albumin 5% or similar colloid. Therapeutic plasma exchange can be performed using either centrifugation or filtration-based device. Centrifugation separates blood components based on density of the individual element. Filtration-based device use membrane that contain pores that allow passage of protein, but not the cellular components. Centrifugal machine can pack red cell to an hematocrit of 8% or higher, and the beer can remove 80% or more of the plasma coming from the machine. In constant membrane filtration system show less powered and usually extract approximately 30% of the plasma. The mechanism of and the benefit of the plasma exchange are hypothesized by removal of antibodies or removal of immunocomplexes, removal of cytokine and adhesion molecules, toxins, and replacement of missing plasma component. Recent studies have considered the utility of therapeutic plasma exchange in the setting of sepsis and thrombocytopenia associated to multiple organ failure. And Guyan, Trank-Guyan, and Carcillo are the most important authors that have showed the pathophysiological mechanism of TAMOF in pediatric patients with septic shock. The study conducted by Trank-Guyan showed that children with septic shock with a thrombocytopenia associated to multi-organ failure had a reduced Adams 13 activity, and autopsies of non-survivor revealed microcirculation thrombosis with von Willebrand factor rich microaggregate. For this reason, in this subgroup of patients, PA was recommended as a priority. A study, single center study by Cavey and colleague were able to show an improvement in survival in children with septic shock supported by extracorporeal membrane oxygenation with a clinical picture or thrombocytopenia associated to multi-organ failure. Going to the topic of the day, the absorption column are new option among in the field of the extracorporeal membrane oxygenation. They are characterized by a very wide surface compared to the traditional membranes. And this characteristic could make them a very effective absorption tool in condition of hypercytokinemia with potential therapeutic efficacy in sepsis and hyperinflammatory condition. Cytosorb is an hemocompatible cytokine absorber whose particular structure allows the generation of hydrophobic bonds with exotoxin, which are absorbed, while plasma proteins are filtered among micropore and returned into the systemic circulation. Already in 2004, in an elegant study conducted by Kellum on in vivo and ex vivo animals, the author showed that the use of Cytosorb was associated with a reduction of interleukin 6, interleukin 10, and tumor necrosis factor alpha level in sepsis model, and that the treatment with the Cytosorb was able to reduce the NFKB induction, but not to decrease the endotoxin level. Cytosorb is an extremely feasible device, and we can use this type of extracorporeal blood purification therapy in many fields: hyperbilirubinemia, hyperinflammatory syndrome, rhabdomyolysis, and intoxication. It's very important to remember that Cytosorb work in a concentration dependent way, and this concept has been shown in many scientific papers. In practice, we can use Cytosorb in a single hemoperfusion in combination with the continuous renal replacement therapy, with the extracorporeal membrane oxygenation, and during the cardiopulmonary bypass in cardiosurgery. The absorption of the cartridge lasts 24 hours and is able to deal since 100 to 700 milliliter minutes of blood flow range. And you can use anticoagulation based on both heparin or citrate. In the field of the hyperinflammatory syndrome, which is the first topic of my presentation, there are today different many evidence in adult population and today also in pediatric population. I report one of the most recent study in adult population by Brouwer and the colleague. The author have conducted the most large observational study and have showed that the use of Cytosorb together continuous renal replacement therapy is able to improve the mortality at 28 days in in confront of the continuous renal replacement therapy alone. Furthermore, the author were able to show that the mortality observed was lower than the mortality expected on the basis of the SOFA score of the patients. About the pediatric population, that is a population in which we have very difficult to have to gain scientific evidence. The first report about the application of Cytosorb was reported by me some years ago in a clinical reports where we use a hybrid blood purification strategy based on Cytosorb and high cutoff filter. We have treated a girl with a refractory septic shock, and we have observed a dramatic reduction of the vasopressor and inotropic load and of the lactate, and the girl has been discharged by the pediatric intensive care unit by 10 days without adverse events. After this first case, other clinical case has been reported, and today in this year we arrived to the first observational study in the pediatric population by our team. We have published the first paper about a consecutive treatment of 8 children with septic shock, and we have showed a significant reduction of the vasoactive inotropic score before and after the application of the blood purification therapy based on the continuous renal replacement therapy plus the Cytosorb, with a significant reduction of the inotropes and the vasopressor by 48 hours. Furthermore, we have observed significant reduction in all the population treated of interleukin 6 and interleukin 10. This year we had another important proof of concept about the efficacy of Cytosorb in the hyperinflammatory syndrome. We reported the first case of application in one of the most significant hyperinflammatory syndrome, the cytokine release syndrome, which is a condition of cytokine storm induced by the advanced immunotherapy. In our clinical case, a boy has received the CAR T cell for a relapsed leukemia, and after 10 days, he developed a severe cytokine release syndrome with an acute respiratory distress syndrome with the need of mechanical ventilation, invasive mechanical ventilation, and intubation, of course. We have decided to treat the boy with CRT and Cytosorb to manage the capillary leak, the fluid overload, but also to manage, first of all, the cytokine storm that we observed. And we after 72 hours of continuous hemoperfusion, were able to show a significant improvement of the PO2-VO2 ratio, with an improvement also of the chest X-ray. And the clinical course has been paralleled by a dramatic reduction of the ferritin level and of the of some cytokine, interleukin 6, interleukin 10, interferon gamma, and tumor necrosis factor alpha. After the blood purification treatment, we were able to wean the boy from the mechanical ventilation, and we have discharged him by 3 weeks from PICU. The experience of using Cytosorb in cytokine release syndrome has allowed us to identify a treatment dosage in the modulation of the cytokine storm. The first important concept is to treat aggressively the cytokine storm, in particular in the first 24 hours of the treatment, changing the cartridge at least every 12 hours. The second important element is to continue the hemoperfusion for at least 72 hours. And the other important element is the benefit of the Cytosorb can offer a sort of synergy with a lot of immunomodulation drug, such as the tocilizumab, the antagonist of interleukin 6, such in this case. The therapeutic schema has provided important indication on the posology of the treatment. In fact, it was also shared by the FDA for the COVID-19 treatment associated to cytokine storm. With the application of the same schema, my colleague in Italy have also published a paper where showed an improvement of the pneumonia induced by COVID-19 in a man of 42 years old. Open problems about the extracorporeal blood purification in pediatric population. Sure, yes, today we have still some problem, in particular in children weighing less than 10 kilograms. Sorry. As we know, children are not small adults, so it's very important to take in mind some important concept when we perform blood purification therapy. Use the right vascular access to have the adequate blood flow rate, selection of the filter on the basis of the weight, of the patient. Remember always the blood eating, and to think with attention to the potential removal of some drug, such as antibiotics, by our device. In conclusion, the extracorporeal blood purification therapy become more widely available in pediatric intensive care unit. This type of support could be an adjunctive therapy in pediatric patients with septic shock and hyperinflammatory syndrome. Plasma exchange is the most important technique, have evidence of positive clinical outcome outcome in pediatric patients with septic shock and hyperinflammatory syndrome, but results are still limited to case report case series. By this year, there are more evidence, and we hope to have always more data. More clinical robust data are needed to clarify the safety and efficacy of this therapy in pediatric population. Thank you for your attention.
Thank you very much, Dr. Gabriela. So I think we will have a lot of questions. I already have quite a few questions, and but as we said that we will try to do all the questions at the end. So if you can kindly
yes, stop the share.
And we can have Dr. Volker Humbert, who is the Director Therapy Management for cytosorbents with so he will be telling us more about some hardcore of what is the Cytosorb thing.
Yeah, thank you very much. Welcome from my side. Thanks also for the very nice and very comprehensive talk of Dr. Bottari. I enjoyed it very much. It's now my pleasure to present you in roughly 10 minutes a bit more about what is Cytosorb. Dr. Bottari has showed you already quite some relevant and important slides, so there will be a bit of a repetition. But anyhow, I'm sure you will learn one or the other thing new about Cytosorb. But however, I will start with a brief introduction of myself. I'm by background anesthetist and intensivist that has worked many years in a large hospital in Munich, affiliated to the Technical University of Munich. But meanwhile, I do work as a director therapy management for Cytosorbents, so the manufacturer of Cytosorb in Berlin. Some words on the adsorber. Cytosorb is an adsorber, so it's not a filter. That's a very important difference. And it's a cartridge which is filled with highly biocompatible, quite little porous polymer beads that have numerous pores on the surface. And you heard it already. The basic technique for removal is adsorption, so attachment onto a surface. And this surface, and that's important, is located in the inner of the beads. It's a rather huge surface. It's more than 45,000 square meters, and it's inside the beads located. So to get there, a substance has to be small enough to enter through the pores on the surface. That's why a size selectivity is given, and the threshold is at around 55, 60 kilodalton. So there's nothing as a black and white threshold. There's always a gray zone, but up to around 55 kilodalton, substances can be adsorbed if they're small enough to enter the bead. But secondly, they also have to be hydrophobic in nature. So Cytosorb does not address hydrophilic substances, which can easily be removed by renal replacement therapy, but the hydrophobic ones, because only they can develop the necessary adsorption interactions. And secondly, and this was also nicely mentioned by Dr. Bottari, there's a concentration dependency, which provides the fact that a high removal efficiency is only given in elevated concentrations, and thereby you reduce the risk for an overtreatment, for reducing mediators down to zero, and you restore a normal physiological reaction. So all this is contributing, first of all, to a very favorable safety profile. As studies and other investigations have shown, there is no significant removal of albumin, there is no relevant removal of coagulation factors or immunoglobulins. And as I just said, there's no complete removal of physiologic mediators. So to our current knowledge and understanding, there is no concern that you bring the patients into an immunosuppressed state by using Cytosorb. Due to the high compatibility of the beads, there's also no activation of the coagulation system or the complement system. And overall, there's only a very low loss of platelets directly by the adsorber. Of course, in septic conditions, you can have a drop in platelets due to the general hyperinflammation. All this is further supported, for example, by the 9th interim analysis of the Cytosorb registry. This is a registry which is run by Professor Brunkhorst from Jena in Germany. And the current analysis covers nearly 1,000 patients, and also they report about no treatment-related adverse events. Generally, we now have more than 100,000 treatments performed worldwide with Cytosorb therapy in a wide variety of critical patients. And based on the feedback of those cases, this still further supports the safety of the device in principle. When we look at the substances which are eliminated, there's a list available in our adsorption spectrum, which we update annually. I don't want to go through every single substance for the sake of time. Of course, in the center are cytokines. Cytosorb, in a way, is a cytokine adsorber, but not only a cytokine adsorber. Cytosorb removes also other important inflammatory mediators, DAMs like HMGB1, PCT, or cell-free DNA, PAMs like bacterial toxins, and then myoglobin, bilirubin, also substances like ticagrelor, rivaroxaban, so antithrombotics. This is a specific indication which is currently given only during cardiac surgery, during cardiopulmonary bypass to prevent bleeding complications. So I will not focus on this in more detail, and other substances as well. And depending on the target substance, of course, you have a different rationale to use Cytosorb in one or the other different clinical indication. Quite many were already mentioned nicely by Dr. Bottari, but here's another list. Depending on what you focus on to remove, you have different approaches to regain control. For example, in septic vasoplegic shock, which is of course the still, I think, overall #1 indication. With nearly the same rationale, you can consider Cytosorb therapy in critically ill COVID-19 patients. I will have some words on this at a later stage. Addressing bilirubin and also inflammatory mediators makes Cytosorb very interesting in liver failure. Myoglobin can also be removed this is why rhabdomyolysis is another indication. And as some toxins or drugs can be removed, there has been a successful use of Cytosorb in various intoxications. From the official point of view, I have to say that this is an off-label use, so not covered by the IFU, but there have been quite some positive and promising reported cases so far. Technically, as also shown before, you need an extracorporeal circuit, but you have various options to do so. You can run Cytosorb as a standalone approach in hemoperfusion. You can even run it with intermittent RRT. In the majority of the cases on the ICU, however, it's run with CRRT, so continuous renal replacement therapy. And based on the system which is used, you have a pre-hemofilter integration or a post-hemofilter integration. This is just or mainly a technical difference. So it's just depending on where you can integrate Cytosorb into. And as I said, there are some fields of application in the cardiac surgery world, which is why you can also integrate Cytosorb into CPB. And there's more and more use coming up in connection or via integration into ECMO systems. The blood flow should stay between 100 and 700. Anticoagulation is needed, but normally doesn't have to be altered just because Cytosorb is additionally part of the circuit. Let's have a brief look at septic shock and vasoplegic shock. I think you all know the pathophysiology, the underlying problem. Infection, that's the definition of sepsis, can lead to a dysregulated immune response, which can then further progress into vasoplegic shock and multi-organ dysfunction syndrome. However, as you surely all know, also sterile inflammatory processes can have a more or less similar dysregulated immune response, which more or less the same clinical picture in the end. So the idea of using Cytosorb is to address this cytokine storm in the first place. However, it's a very broad field of action, as Cytosorb is also addressing other important parts in this problem. So it's removing PAMs or DAMs. It has been shown to reduce the de novo production of cytokines by interfering with nuclear factor kappa, and it's supporting organ function of liver and kidneys. So providing a very broad approach to modulate hyperinflammation. Importantly, it's an adjunctive therapy. So it's not meant to replace any of the other important standard therapeutic measures. But as you know, in some patients, these measures are not good enough. So whenever you can stabilize a patient properly, that he recovers with the standard measures, there's no need to think about Cytosorb. But there are quite some patients that you cannot stabilize properly with your standard measures. And these are the patients when Cytosorb therapy should be considered additionally. And the major criteria for defining stability is the hemodynamic stability, which is on the one hand understandable when you think about pathophysiology. of hyperinflammation, that this is leading to vasoplegia, to vasoplegic shock. So hemodynamic instability is a major criteria for considering Cytosorb therapy, and hemodynamic stabilization is the major therapeutic effect of Cytosorb therapy. You have to be rather quick with your decision because, again, supported by pathophysiology and also supported by more and more publications, ideally the plan to use Cytosorb should come up within the first 6 to 24 hours after diagnosis of shock and start of standard therapy in this regard. The evolution of the evidence, I think, looks quite nice. We're not there where we want to be. Of course, we need more data, more RCTs in the end. But however, I think there's a nice evolution with a couple of studies. These are, of course, not the only ones, but just major ones. It all started with some studies that mainly looked at safety and feasibility. With more and more understanding and experience, there was more and more the clinical effects in the focus. And this is mainly, as I just said, hemodynamic stabilization. So it's shock control, even shock reversal, vasopressor reduction, and hemodynamic stabilization. And there's a recent nice study, which was also presented by Dr. Bottari, that was also focusing on mortality. And after having applied a statistical model, they could show mortality benefits with the Cytosorb. And yesterday, that's why I included it as hot off the press in today's presentation, we received another publication from Austria. Here they examined overall 42 septic shock patients that have received CRRT and Cytosorb therapy and compared them with 42 control patients. They used the so-called genetic matching. So I'm not that much into statistics, I have to say. It's a very sophisticated matching to come to a very comparable baseline. In the end, the Cytosorb patients were still kind of sicker, had a higher SOFA score and higher norepinephrine levels. However, when you compare those two groups, on the one hand, you could show that the catecholamine requirements in the Cytosorb group were half within 24 hours after start of the therapy, which was not given in the control group. And even more importantly, the in-hospital as well as the 28-day mortality was significantly reduced in the Cytosorb group in comparison to those control patients. So very nice results from this point of view. It's not an RCT, it's a retrospective analysis as well, but I think it provides very nice signals that Cytosorb therapy can also have quite positive effects on mortality. Some words on COVID-19. The rationale and principle is very much the same. So also here, hyperinflammation is a problem in critically ill patients, and modulation of hyperinflammation is the same target as in sepsis when using Cytosorb. Nicely, there have been quite some recommendations from various countries to use Cytosorb in this setting, from Italy as presented, also from Panama, Colombia, China. The US FDA has granted emergency use authorization in April, and in India, there was DCGI approval in May. Additionally, the WHO listed Cytosorb therapy for non-drug life-supporting COVID-19 patients. That's not a recommendation, but I think it's still a kind of recognition of the therapy in principle. And the current understanding when to use Cytosorb therapy in critically ill patients is displayed here. So in patients with either refractory vasoplegic shock or moderate ARDS, ECMO ECLS initiation, AKI stage 3 with start of CRRT, which is coming from the Italian guidelines, or as it was found that quite some patients have COVID patients have a cytokine profile quite similar to HLH, secondary HLH, and we know that Cytosorb therapy has quite promising effects shown in those patients. An H score defining or diagnosing HLA might be another criteria to consider Cytosorb in those patients. We're still learning every day anew. The data so far already look quite nice. We have quite some webinar data presented during various webinars from Spain, Ecuador, Italy, and many other countries, Germany, the US. We have published case reports, even an interim RCT published already, but the RCT is ongoing, and now also some case series. Last week, very nice publications from Italy and Saudi Arabia. And these all are further supporting that Cytosorb therapy had effects on reduction of inflammatory mediators, effects in regard to stabilization of hemodynamics and reduction of vasopressor needs. So as also known from the septic shock field, but as quite some COVID patients have a problem in lung function, also here, improvements in lung function were seen. Italian publication was even pointing towards an improvement in the clinical course when you started Cytosorb therapy even prior to intubation. First signals, of course, but very promising signals overall. Some words towards the end on liver failure and rhabdomyolysis. These are two other very promising and nice fields. The idea behind liver failure, as you know, liver failure has the problem of accumulating of liver toxins and immune dysfunction. Cytosorb can address the two of them, liver toxin removal plus immunomodulation. And there are quite some publications available in this regard. The idea with rhabdomyolysis is in principle not too different. Also here, you can have two problems. You can have the myoglobin contributing to acute kidney injury, and you can have a dysregulated immune response, either as a consequence or as a trigger of rhabdomyolysis. Again, Cytosorb does address the two of them, and also here, some first case reports are available. Having said this, I'm at the end. Learning is experience. I think the best learning is if you do it by yourself. And overall, the evidence is nicely growing. As I said, meanwhile, even more than 110,000 to be precise, more and more documented treatments, more and more patients, publications, and also finally, clinical trials. And with this, I'm at the end of my talk, and thank you very much for your attention.
Thank you very much, Dr. Humbert. That was a very excellent brief overview of the whole of Cytosorb. So we will now move on to Dr. Satya Prasad, and who will be telling us about our Indian scenario, because all of us really wants to know this, that are we using Cytosorb in India, and if so, how are you coping with the finance, because that itself has often been a major barrier in using Cytosorb, at least from our Kolkata experience.
Thank you, Dr. Rajiv. So after two excellent lectures, in this session, we are going to discuss about our experience, our Indian experience. So role of Cytosorb as an adjuvant to CRRT in children with multi-organ dysfunction. Cytosorb is a unique hemoabsorber intended as adjuvant treatment for patients with elevated cytokine levels in the setting of severe sepsis or septic shock. It is very easy to set up in any extracorporeal sector, either HT, SLED, CRRT, or ECMO. We know already, we discussed it in previous sessions. We know like usually CRRT was with diffusion and convection, whereas Cytosorb is an adsorber. Our experience, this is the first study on Cytosorb therapy in pediatric age group from India. This is also largest study that compared usefulness of Cytosorb versus CRRT alone and effectiveness of early initiation of Cytosorb in pediatric patients with MODS. In our study, we had one 7-month-old child who is weighing only 6 kgs, which is the smallest child reported to have received Cytosorb therapy from India. What are the primary objectives here? To study efficacy and safety of Cytosorb hemoabsorption therapy in children with MODS and septic shock. Coming to secondary, to compare early versus late Cytosorb therapy for their impact on outcomes. The methods. Study design is, this is a single center retro prospective study. Study duration, this is we have done from November 2018 to October 2019. And the database, this is hospital database, Rainbow Children's Hospital, Banjara Hills, Hyderabad, India. The eligibility criteria and screening all patients of either sex, aged more than 1 month and less than 18 years. With MODS receiving CRRT, this is group 1, or CRRT plus Cytosorb therapy, this is group 2. Data was prospectively collected from 10 patients who received Cytosorb therapy during the study period, that is from November 2018 to October 2019. To compare them against the children with MODS who received only CRRT, we collected retrospective data who matched the Cytosorb group in terms of weight, SOFA scores, and VIS scores. The results coming to mortality rate, In only CRRT, the mortality rate was 53%, number was 15 patients. Whereas CRRT plus Cytosorb therapy, the mortality rate was around 60%. This is the number of patients were 10. Coming to other results. In group 1, CRRT group, lactate and procalcitonin significantly reduced after 24 hours and 72 hours of treatment with p-value of 0.019. Whereas in Cytosorb group, group 2, after Cytosorb therapy, lactate showed significant reduction post 48 hours of therapy with p-value of 0.041. Coming to others, important thing is lactate. This is in Cytosorb group. Lactate showed significant reduction with p-value of less than 0.009 post 24 hours. Post 48 hours, it was less than 0.001. Even post 72 hours, it was less than 0.001, which is significant. Coming to early Cytosorb versus late Cytosorb. Coming to late Cytosorb, the mortality is 100%. We had 4 patients actually, we lost 4, where we have started Cytosorb quite late. Whereas in early group, we have 6. Out of 6 we lost, but 4 survived. So mortality rate is 33%, even though p-value is not significant because of small group. Very few studies have actually measured the cytokine levels, mainly IL-6, during the Cytosorb therapy. And all those studies have shown variable and unpredictable levels of IL-6 post Cytosorb therapy. Even in our study, we measured IL-6 levels during Cytosorb therapy in 3 patients, and we too found inconsistent response. So coming to efficacy in different things like ferritin, IL-6, VIS, SOFA score, Cytosorb score, and PCT. Ferritin eventually stable even showed rebound increase later on, whereas VIS showed very good improvement and showed reduce very well even post 24 hours, post 40 hours, even over 72 hours. And p-value is also significant here. Coming to survivors, in Cytosorb group, again same thing, VIS levels decreased over 72 hours, but p-value is not significant. Even Cytosorb score also reduced over 72 hours. Here p-value is also not significant. This is the details of the patients. We have 10 patients. And the patient A, he is only 6 kgs. And we have used 3 Cytosorb cartridges with very minimal blood flow because patient weight is only 6 kgs. Because of we have to keep hemodynamically stable, we have done with very minimal blood flow. And Cytosorb hours is 18, 20, and 18 hours with 3 cartridges. So the removal in cytokines may be counterbalanced by cytokine shift from the interstitium into the blood compartment, thereby negating any overall effect. Hence, experts recommended using VIS score and SOFA score to be used to decide the time of initiation of Cytosorb therapy and also to assess the response to therapy. In adult studies, starting Cytosorb therapy early, that is in first 24 hours from the identification of high VIS scores and MODs, is considered more beneficial than late therapy. In our study, early Cytosorb therapy with associated with better survival rates. However, not found statistically significant. This is more because of small sample size. The optimal length of treatment is still undecided here. In adults, usually they do with good blood flow, like 200 ml per minute, and they do over 6 to 8 hours. And usually they'll repeat for 3 to 7 days. Whereas in small kids, where you can't do with that much of blood flow, you have to do with minimal blood flow to maintain hemodynamic stability. That's why we have to do for more number of hours. What are the limitations? Important thing is small sample size. Studies with larger sample size may be needed. And this is again single center study. We should do multicentric studies. And prospective sample of Cytosorb group here is compared with retrospective data of CRRT patients. So may have inherent bias, although we took utmost care to avoid bias. So children with MODS with high VI scores do benefit with Cytosorb therapy, showing significant reduction in metabolic and hemodynamic parameters like lactate and VI scores after the initiation of Cytosorb therapy. Compared to CRRT therapy, Cytosorb therapy could not show any survival benefit. But in our study, early Cytosorb therapy have good survival advantage over late Cytosorb. In late Cytosorb, we have done in 4 patients, we lost all 4. Whereas in early Cytosorb, where we have started early within 12 hours, most of the patients. So out of 6, 4 survived. Even though not that much significant because of small sample size. A multicentric randomized control trial on much larger sample size will be more appropriate approach to answer this question. So impact on clinical practice. Cytosorb is easy and safe to use in the management of septic shock or MODS in children. Decision of initiation of Cytosorb and subsequent assessment for response to Cytosorb therapy should not be based only on serum ferritin and IL-6 levels. Using VAA score and SOFA score is better strategy in this regard. Thank you very much.
Thank you very much, Dr. Satyaprasad, for that excellent overview and also keeping well in time. So now we throw the session open for discussion. We have got few questions already, and but before taking on the question, I'll ask Dr. Giri. Dr. Prabhas Pasum Giri is our intensivist, pediatric intensivist. Prabhas, are you there? Prabhas?
Yes, I'm there. I'm there.
So, do you have any specific question? Because this is quite a bit of a focus on pediatric intensive care. So that's why you might be having more relevant questions than us.
Yes, the study
And
about
sorry, and if you can just unshare your screen also in that by that time. Yeah, Prabhas, please.
basically what I got to know that the most of the studies of the Cytosorb has been done in adults. There are very few pediatric studies. Most are limited in the case report and case series. So we need to know that whether this Cytosorb therapy is effective in all types of hyperinflammatory syndromes or hypercytokinemias, or in limited numbers. Like there are different basic etiological agents that can give rise to this hypercytokinemia or hyperinflammatory syndrome. Like the most common hypercytokinemic features that we got in severe dengue or dengue shock with multi-organ dysfunction. We got a very high IL-6. We have discussed few times with our nephrology colleagues whether we can start CRRT and Cytosorb in these patients or not. So dengue and few other viral infections like in the era of COVID, sometimes in terms of adenovirus, H1N1, we're getting sometimes we're getting very high ferritin IL-6 report results like hypercytokine. It's the one variety of patients. Another variety of patients are typical of bacterial septic shock, specifically a gram-negative sepsis or even a gram-positive sepsis, hypotensive or multiple inotropic agents, DIC. These are having some secondary HLH-like features or multi-organ dysfunctions with hyperferritinemic sepsis. These are another group of patients. Number 3 group of patients is basically a pure hemophagocytosis and are genetically confirmed hemophagocytic patients that are usually very much smaller kit and smaller size associated with hypercytokinemia. And number 4 are the pure rheumatological cases, like underdiagnosed case of SLE or juvenile arthritis or JDM that went into macrophage activations with a sky high ferritin and IL-6 and everything. So basically, we are getting this 4 types of hyperinflammatory or hypercytokinemic patients. In all these types, the cytokine storms are going on, and number 5 types is basically a acute necrotizing pancreatitis with SARS and MODS. So we are getting these types of cytokine storm. So whether Cytosorb is applicable, or we can apply in all these types of cytokinemia or hypercytokine storm scenarios, or we need to specify, no, these are the scenarios where we can apply, or there are some differences in the application depending upon the primary etiology.
Yeah, I think that's a very relevant question, and I also had that question. Like exactly how do I choose to use Cytosorb? We understood that early use of Cytosorb is important for success, but how to choose, and secondly, whether there are any biochemical parameters, like we were initially told that maybe IL-6 is an important biochemical parameter, and if your IL-6 is high, then only do Cytosorb. Is that the fact? Do you use a combination of them? So if Dr. Gabriela can first address this, and then maybe Dr. Satyaprasad.
Yes, regarding the time of start of extracorporeal blood purification with Cytosorb, I agree that an early approach is sure better. I would like to comment that when we talk about multiple organ dysfunction is a bit and a bit scarce the definition to understand with when we have to start, because multi-organ dysfunction is two or more free organ in dysfunction, but this condition does not describe very well when we have decided to start. What we know today is that when we have a septic shock, Cytosorb can be a valuable adjunctive therapy in condition of a refractory septic shock with an increase of lactate and a high vasopressor load with unstable hemodynamic despite the standard K. What I have often noted during my clinical experience is that the window to decide to start is not too long in the time. We have decided in time when we see that the standard therapy is not working and persists a state of refractory shock to start the blood purification therapy, possible before a multiple organ failure has been observed, in particular in septic shock, because when we already have a mitochondrial dysfunction, it's too late. We have to work before, a bit before. That is not, of course, with an light doses of vasopressor and inotrope, but when we see that we are in a condition of a catecholamine resistant septic shock. Regarding the biomarkers, of course, not every hospital has the possibility to have the interleukin 6, interleukin 9 at bedside. So very often clinicians use protein C reactive procalcitonin as a surrogate biomarker. These biomarkers are a bit as I said, we can follow them, but we have to know also that our blood purification can remove the biomarker, and so we look for something that is not always correlated with the clinical course that we observed. Another situation population is for the cytokine. Of course, the best choose is when we have high doses of cytokine, how we have said, because cytosol work on high concentration. So higher the cytokine, higher the benefit. But as I said, of course, not everyone have this the cytokine at bedside every day disposable. The other concept important is the use of ferritin, because ferritin can improve in different situations, because ferritin is correlated sometimes with a secondary HLH for an infection, for a rheumatologic disease. And but sometimes is also ferritin for a primary LHH. In my
So yeah, that's what I was going to ask you. Like in your clinical practice, what do you do? Because we are at a hospital where, at least at our institute, we can get Intel IL-6 within 2 to 3 hours during the daytime, and we can get ferritin also. But
Okay.
our question is still the same. That when do we start thinking of Cytosorb? It is like a child who is on one inotropes and ventilated, or a child who is not even ventilated but requiring one inotropes or two inotropes. Exactly when? And the other thing was that Dr. Satya Prasad mentioned about this SOFA score. But then is that for pediatric also, or is it
No.
only for the adult? So
Yeah.
what score? Like, do we have any score in pediatrics where
Yes.
we can use it?
Yes, in fact, I conclude for the ferritin to see that in my experience, we are going to publish a work about LHH in children and cytosorb therapy. And when you have a secondary LHH, the efficacy of cytosorb is very good. In primary LHH, as we need the hematopoietic transplant is the therapy. In these patients, sometimes cytosol does not work, but in secondary HLH, we had good result. For the SOFA score, yes, I would give a comment, because SOFA is not a score for the pediatric population, and I suggest to the colleague to use the payload score. In our prospective trial that is ongoing in Children's Hospital Bambino Gesù about septic shock and cytosol therapy, we use payload every 24 hours to monitor the multiple organ dysfunction. Of course, I can't give the result because it's ongoing, but I suggest to use the payload score.
And sorry, and have you used any cutoff for payload score for starting Cytosorb?
No, for the payload score, usually we use the payload score as outcome, not as
as a
criteria
initiation
to start. What I use, I see the vasopressor load when we the cytoscore is a nice tool to I think that the colleague referred to the cytoscore of Kogelman, I imagine. Yes.
Dr. Satya Prasad, it's to you, like, and that was also a question, like, what is Cytosorb score? At least I don't know Cytosorb
the
score.
Cytoscore by Kogelman is a preliminary score that this Dutch colleague are perhaps Dr. Walkman can say more about it, but it's interesting because it uses some parameters to decide and to evaluate the efficacy of cytosol when to start. One of these is how much vasopressor and inotropes you are giving. If you use one or more vasopressor or inotropes, the level of the lactate and the time of, if I remember well, the time of the septic shock. But is a score that is going to be to be validated, I think. In my experience, I decide in septic shock, I decided to use always Cytosorb in refractory septic shock. That is catecholamine refractory shock. When I use high doses of catecholamine and the clinical course is not better.
So how many catecholamines? Like if you go from if you need to go from 1 to 2 or more than 2?
For example, if you go above 0.1 microgram per kilo minutes of noradrenaline or adrenaline, and you need a second inotropic or vasopressor, this is the time to start the Cytosorb.
So that is quite that will be quite useful then. Like we have, like you are saying that if we have to go to, like we have reached the top level and we have to add another stimulant, then we should be considering Cytosol.
Yes, and the other, if you want to translate it with the vasoactive neurotropic score, is with a vasoactive neurotropic score more than 15, 20 in general.
Okay.
And sometimes consider that lactate increase later when the mitochondrial dysfunction is ongoing. And when the mitochondrial dysfunction is ongoing, Cytosorb is not a miracle. So you have worked a bit before.
Thank you.
Yeah, great. Yeah,
so
this one Cytosol
yeah.
what we discussed. Usually the initiation of therapy, no, that depends on, usually we do calculate Cytosol score. So early start, usually like even the score is around 8 also, we do start if child is hemodynamically unstable and if child is having any multi-organ dysfunction. And usually these points depends upon 5 parameters. One thing is hemodynamic stability, other thing is renal parameters, creatinine, urine output, oliguria, and whether child is requiring RRT or not. And other thing is respiratory support, whether child is on ventilator or not. Okay, how much is the hypoxemia? And other lab parameters usually that includes lactate. Okay, how much it is based on the lactate and PCT and CRP. These are the lab parameters.
Any lactate level that you use, because that's one
again,
of the.
We do give based on the severity. We do give 1 to 3 points based on the severity. We do give 1 point, 2 point, 3 points based on the severity. Lactate again, like less than 2 millimole, we do give 1 point. Again, if in between,
so then, like what you are
points, more than 4 millimole, 3 points. Yeah.
So what you are saying that you don't go just by lactate parameters. You ultimately you put it into the Cytosorb score, and then is this validated for pediatric or is it primarily for adult?
Yeah, we are following this. This is for pediatrics also. We are following this. Okay.
So, Dr. Humbert, do you want to add on to this Cytosorb score, like and taking on my question that are we okay to use it for pediatric, or is there any concern in this?
I think, first of all, if I understand it right, we have to differentiate, because there are, to my understanding, 2 scores. One is the Kogelman Cyto score, which is only looking at hemodynamics and lactate changes over a period of 6 hours. So he is taking into account the starting values and then reassesses the situation after 6 hours. And based on this, you get certain points. And to the current understanding, starting from 6 to 8 points onwards, it should make sense to consider Cytosorb therapy. The score the Indian colleague was speaking about is a more comprehensive score, also taking into consideration renal function, respiratory support, so they should be separated. And I am not that much into the Indian score, apart from knowing that it exists. The Cyto score is currently validated, but we have to say it's validated based only, and strictly speaking, so far only based on retrospective data, so not yet in a prospective manner. And even more important, so far, not any children values have been included in the analysis. So it's based purely on values of adult patients treated with Cytosorb therapy. So that's why I don't want to exclude that the idea behind using the score is probably also applicable on pediatrics, but whether or not the points or the ranges, the thresholds are the same, of course, has to be investigated further. Importantly, what Dr. Bottari has said a couple of times is really that you don't wait too long for starting Cytosorb therapy. You will still lower cytokine levels, but once certain damages has been done, like mitochondrial dysfunction or other, if a cell is already dead, you can't resurrect it with Cytosorb. It's not a magic bullet. It can calm down the cytokine storm, but things that are irreversibly damaged will stay irreversibly damaged, and then you will have not really a result. And interestingly, from the study I showed just with this, with one slide that was published yesterday, they made an analysis and could somehow show that lactate levels above 8 were correlated with a very poor outcome. And similar results are coming from this Brouwer study. This was the other study also presented by Dr. Bottari from the Netherlands that could also show mortality benefits in a model. And also they have analyzed that lactate levels, I think above 6 or 6.5 were also quite associated. So potentially we could also find a criteria which rather should make us more cautious to initiate Cytosorb, because maybe you can't win in the end. That's not for sure, of course, yet, but these are the results that elevated lactate can be a trigger, but maybe from a certain point on, 6, 7, 8, you might be too late in the course. But again, this is only on adults so far, so it might be different in children. I know too little. I was an adult intensivist, so maybe lactate kinetics are different. Dr. Bottari and the Indian colleague, of course, know better here.
So,
important,
yeah. So, if I can summarize it, in pediatric, when to start a Cytosorb, do I understand that still it is not just a particular score, but it is the overall picture as such, and an early start is better. Maybe once you are above 1 inotropes, then you should start considering it. And interleukin 6 per se is not an indication, you don't have to have the interleukin 6.
Yes,
absolutely.
Yeah. And there were certain scenarios I remember that it was all falling in the criteria, like the child was sick, we had a sepsis, had gone to now 2 inotropes, but the interleukin 6 was low or was just slightly normal, like slightly above, and we decided, no, this is the IL-6 is not very high, it is not an indication for Cytosorb. Any comment on that, Dr. Bottari, Dr. Satyaprasad?
Now we are following actually VIS score that is giving good response. VIS score was a support score.
I was saying that in our case, the IL-6 level was normal or just above normal, not very high, and otherwise the child was on double inotropes and leading on.
Yes, consider that IL-6 is not the only biomarker of in the hyperinflammatory syndrome. There are multiple partners of cytokines, and they differ if you have an HLH, if you have a septic shock. There are different patterns of hypercytokinemia. So I suggest that you have not to focalize only on interleukin 6. And the other element that I suggest is to refer, when we talk about refractory septic shock in children, to the ESPNIC definition. Now we have a definition of the European Society of Pediatric Intensive Care that define what is the refractory septic shock in children, and we have the bedside refractory septic shock score to evaluate it. It takes in consideration not only the lactate, usually 2 or more is indicating something that is going wrong, but also the trend during the time, the cardiac dysfunction, and the vasoactive inotropic score. These are the 3 elements of the definition by ESPNIC by refractory septic shock.
Okay. Any of our faculty, they have any questions? And while they're thinking, I'll ask one more question. Because I'm quite fascinated about how did you do this Cytosorb in such a small child, a 6 kilo child, like this extracorporeal blood, the
The
blood flow rate.
surface area is so large to prevent like hypotension. We have been good inotropic support, and we have cut down blood flow. But if you cut down blood flow, obviously efficacy of the Cytosol filter goes down.
Yeah, because it's said because your blood flow rate was 50, you said.
Yeah.
And the child's weight was, if I 6 or 7 kilo.
Absolutely. 6 kgs.
So 6 kilo.
Kgs.
So it is still quite high, no? 10 ml per kilo.
The important thing is we have primed the circuit with blood, PRBC, and we have increased the doses of inotropes, and some way we are able to manage with good inotropic support with priming. Always priming is also very important in pediatric age group. So priming the circuit, that is the important thing. Even hemoglobin is normal. Usually we do prime if child is less than 10 kilos.
So this particular child was also on a couple of at least inotropes, right?
Yeah. He's on 4 inotropes.
Dr. Gabriela, you want to add anything on that, like doing this in small children?
Yes, as today I consider the weight as the only problem that we have to manage when we have decided is a problem, because we have an high prime volume, and the safety rule established that we have avoid to have an extracorporeal blood volume not too much 10% of the total blood volume of our patient. So I agree with the colleague to use to use the blood priming of the circuit, and if possible to give plasma, fresh plasma frozen, and platelets, because you in these so small children are a risk of hemodilution. Sometimes in these children there is a risk also of hypotension, we know, and we have to balance the potential adverse events. So we have managed with care the smallest children.
And once you start Cytosorb, you use it for at least 24 hours, is it?
Yes, I use always Cytosorb for 24 hours. The continuous perfusion is one of the tips that I recommend, because to have a session less than 24 hours don't reduce the efficacy of this device. What you can do is, if you have a cytokine storm, so a very hyperflammatory disease, is you change the cartridge 2 times per day to improve the remove of the mediator. But yes, of course, I suggest to have an hemoperfusion in 24 hours that lasts, if you have a clinical picture of instability, for at least 48, 72 hours, so for 3 days at least.
Any question from the faculties? Dr. Susmita Subhankar?
Can I ask, related to the question that was asked for about smaller children, so I assume there is only one size available, right?
Yeah, absolutely.
And why is that? Wouldn't we require at least one pediatric size? Is that somewhere in the plan?
Yeah,
that's for Dr. Humbert to answer.
It's a very good question, and those are also discussions we have in the company to think about this. There's a high regulatory hurdles to overcome, but those discussions and ideas are already there and discussed quite intensively, because we see the need for it and we see promising results in the pediatric field. So it was started with one adsorber, and we're still a kind of relatively small company and busy enough to concentrate on that many things, but it's a relevant question, and we're working on it. Without saying any timelines, it's just that it's a topic to be discussed. There isn't any final decision. So, but it's definitely an important question.
And Dr. Humbert, since we have you, so albumin is not lost. IVIG, is it lost? Like if you are giving IVIG, do you have to stop Cytosorb or not do Cytosorb?
No,
Yeah, immunoglobulin.
Albumin is not lost and the immunoglobulin is not lost, because we have to remember that we have a target of 72 maximum, 72 kilodalton of molecular weight as cutoff. So albumin is not loose and immunoglobulin are higher.
Exactly.
Dr. Subhankar,
what about other drugs, other routine drugs, antibiotics, blood products? What happens with those?
It's a relevant question. And of course, as every extracorporeal therapy, there is the concern or the issue that there's an unwanted drug removal. And the most important drugs in this regard are, of course, antibiotics. We have investigated this and are currently investigating it further. To the current understanding, fortunately, the majority of the relevant substances are not removed to a relevant manner by Cytosorb in any way. At best, of course, we recommend therapeutic drug monitoring. The substances which, to our understanding, are relatively speaking at most risk to be removed to a higher extent is fluconazole, vancomycin, linezolid, and amphotericin B. Those are the substances where animal experiments, other investigations with pharmacodynamic models have revealed a relatively higher extent. However, the majority of all the other substances, antibiotics and others, are not removed to a relevant extent to our knowledge. But this is not stopped or finished the investigation. It's ongoing, as it's an important question. But when we look generally at the field, we have many successful uses of Cytosorb without any dose adaptations, without anything in this regard. So it points to that overall, it's not a very big issue, but of course this cannot be said for every single substance in detail. That's why we're investigating it further.
It's an adjuvant to CRRT, either CVB-HT or CVB-HR SLED. So we should adjust the doses because this Cytosorb is adjuvant to CRRT. So we should be careful.
Of course.
Subhankar, you wanted to ask any question? We cannot hear you.
Can I ask a question?
Yeah, Parita.
Basically, it's a fascinating discussion on newer modalities of treatment in various kind of shock, particularly in septic shock in children. My question is to Dr. Satya, and I'm sure Dr. Humbert will be, really chipping in, because when you reduce the flow to actually, suit our pediatric patients, and even if you actually do it for a prolonged period, does it actually, affect the effectivity of Cytosorb in the absorption of different toxins and cytokines that we are aiming it for?
Removal is a bit slow if you're doing with less blood flow. That's why we have to do more number of hours. In adults, usually they do 6 to 8 hours, whereas in kids, we do even 24 hours also to improve the efficacy. And other important thing is with less blood flow, chances of clotting is a bit more. So we should be careful about PT. We have to do ACT and PTT-PT if we have facilities ACT. And accordingly, we have to adjust the doses of heparin also to prevent the clotting. Main problem is clotting. If you're doing with less blood flow, the important thing is patency of the Cytosorb filter. So we should be careful about it. So we can increase the duration. If you're doing with less blood flow, you can increase the duration to get the optimum response. But important thing is clotting.
Have you used?
By doing so, are we compromising the net effect? Dr. Humbert, is there any study which is actually showing similar efficacy by reducing the flow but giving it for a prolonged period of time?
There are not studies in a patient where this can be compared, and it's never possible to compare the same situation as this is then done if you used it for the first time, but there are some laboratory studies to test the effect of different flows. And of course, in principle, the higher the flow, the higher the blood volume you purify. However, the adsorption process by itself on the contrary, is better with lower flows, because if the flow is too high, then you can imagine the substances rush through the beads and don't have any chance to get stuck to the inner surface. That's why overall, with higher flow, overall you will purify more blood, so remove more substances overall from the blood, but it's not a linear effect. So with, let's say, 300 mils per minute, theoretically, you don't purify 3 times as much as with 100, because in principle, absorption is better with lower velocity because it enables an absorption better. That's why I think, in principle, we recommend higher flows. Whether this really makes a clinical difference, I don't think so. And the major issue for having a certain flow is the clotting. We have shown that the minimal flow for official reasons from the IFU is 100 mils per minute, knowing that this is sometimes not working in children, but that's the official lower limit. The upper limit is based on the risk for hemolysis, but this is not with CRT, this is with CPB or ECMO, and this is 700 mils per minute. So that's the technical frame. Clinical studies, whether this is really relevant, I don't think are not there yet, and probably difficult to perform. However, what's also important that Cytosorb therapy should not necessarily be stopped after the first adsorber. In many patients, you simply need a second or third or even more adsorbers, even if this, of course, increases the costs. But that's with every therapy, that you have to dose it individually, and you should really re-evaluate the situation after the first adsorber, whether further improvement is needed, and then to continue with another adsorber. After the latest 24 hours, sometimes even an earlier change might make sense.
Dr. Satta, have you used it with SLADE?
Usually we won't do SLADE. Usually we do CVVH. So we do like CVVH or CVVHD or HDF. Usually we do combine with this.
And there was this query on the about
SLADE,
the
in pediatrics, like if you do SLADE along with that Cytosorb, SLADE itself, like child will have hemodynamic instability, the kid is small with lesser weight, and if you add Cytosorb to that, again it increases the problem. So we should be careful.
So then it will be mainly for a bigger child, like
yeah, if child is big with good surface area, then we can try. We can do with SLADE also. Yeah.
And people want to know about the cost from Dr. Satta.
I think they know that is 90,000. I think each filter, 80 to 90,000, and along with that, again you have to do CRT also. So that adds on to that. CRT cost plus Cytosorb filter. So yeah, they have to pay much.
So your family were all the corporate, or like not necessarily?
Most of the people. Sometimes we do get from charities. They do support. They'll give support. So yeah, otherwise it's very difficult to do these things. Yeah.
Subhankar, you had a question. If you're no, we can't hear you. Sorry. So we are running out of time. I have got 2 more questions. If nobody else, Jayatidi?
Are there any side effects that we have to monitor for during the therapy?
No side effects can I replay. I observed in my clinical experience. As I just said, you have give attention when you have children more than 10 kilos. Usually I prefer to use the blood priming to avoid hemodilution, and I optimize also the blood, the intravascular blood volume of the patient before to start, in order to avoid hypotension. You can observe also a slight decrease of piacinopenia, and I suggest to give the platelets only after 1 hour to have the starting of the extracorporeal circuit, to avoid that the platelet have an adhesion to the cartridge.
Dr. Botari, you mentioned about the use of the tocilizumab. So are you using it regularly for like septic before.
Tocilizumab?
Yeah.
Tocilizumab is the antibody against IL-6.
Yeah, IL-6.
Not, we don't use tocilizumab for septic patients because there are not evidence about the monoclonal antibodies in pediatric septic shock. The trial have shown that there are not an improve of survival or other parameters. In the clinical case that they have showed is a different condition, is a cytokine release syndrome, yes. And tocilizumab is recognized as the one of the first line therapy for these patients.
And lastly, if nobody else has question, suppose you are in a scenario where you have got all the extracorporeal mode of therapy available to you. So with the current evidence, what would you use in a child septic on multi-drug anatropes?
So can you repeat? I don't understand.
Suppose you have all the modalities of extracorporeal therapy available to you. So you went to like the high volume CVVH, then the therapeutic plasma exchange, as well as this new thing, not the new, but the auxiliaries and everything is available to you, including Cytosorb. Which one would you use?
Which one I have used?
Which one would you use? Suppose you have got all the modalities available to you.
And I haven't Cytosorb?
You have the Cytosorb also. Everything
okay. As I said in my presentation, you have to choose on the basis of the target molecules, okay, and then clinical setting. Of course, you have if you have a clinical picture of thrombocytopenia associated to multiple organ failure, as Carcillo has shown, there are the von Willebrand microaggregate that are very, very heavy, okay? And so only plasma exchange can remove the von Willebrand macroaggregate, okay? But in condition of hypercytokinemia, I think that as today, my first choice is the Cytosol because as an high power, because it has an high surface and is very, very efficient to remove cytokines. Of course, other author, for example, in HLH, Carcillo suggests to use plasma exchange, but I find that that is inappropriate to use plasma exchange in HLH because the partner is a cytokine partner. You don't have antibody to remove, and so the cytokine can work. The Cytosorb, sorry, can work. About the auxiliaries, what I can say, auxiliaries is an hemofilter. So we have remembered the difference between an hemofilter and an absorbing column. Hemofilter are used for the hemodialysis and work for convection, diffusion, and a little for absorption. Cytosorb has an high power of absorption, are different things. You can combine, as I done in my first report, I combine Cytosorb and the high cutoff filter. You can combine, but if you ask me about the best tool as today that I have proved without any conflict of interest, I can say that is Cytosorb. Also because Cytosorb work in 24 hours, and so you don't give to the patients instability to give session for 3 hours and then change. And also because you can work together with continuous renal replacement therapy. For me, it's very important to combine Cytosorb and continuous renal replacement therapy because children very often have fluid overload, that is a cause of mortality, as you know. And so to combine these two technique is, in my experience, very, very useful.
And for TAMOF, you don't wait, like you don't do this Adam TSD, like you don't wait for that level. It is again a clinical decision, right?
Sorry?
For TAMOF, for starting plasma, you don't measure the Adam TS activity. It is basically a clinical decision for starting plasmapheresis.
Yes, if you can, you should dose the Adams 13 activity to show that there is a reduction of the Adams 13, a reduction that can depend by antibody, congenital, different causes. But sometimes the dosage of Adams 13 need time, and you have to work. So if you have a clinical picture of TAMOF, I think that you are authorized to start the plasma exchange.
Okay, at least for me, all of this discussion was very, very illuminating. And if nobody has any other question, it is getting late, at least in India, it is getting late. And Dr. Satya must be wanting to going to dinner. So any other comment from any of these panelists? Dr. Satya, Dr. Humbert, Dr. Butari, any comment?
Thank you. It was an interesting event, and I look forward to meet you in other occasion. It was a very interesting exchange of opinion and of experience.
Thank you very much, Dr. Butari, and I do hope that we have such sort of updates quite frequently, so that like we are quite interested definitely in this Cytosorb, but at least in Calcutta, I don't think we have used in as much as we would have loved to. And there is some sort of inhibition from the intensivist side. And as Dr. Satyaprasad knows, like these children are usually under the intensivist. So thank you, Dr. Satyaprasad. Thank you, Dr. Humbert, and thank you very much, Dr. Butari. Thank you very much.